Helga, do you just want to try sharing your screen? Yeah, that's good. That's good. Yeah, you can stop sharing just for my intro and then start sharing again. Hello, Ellen. Good afternoon. Hello, Ellen. Good afternoon.
Hi. Yes, good afternoon, Milind.
Hi.
How are you?
I'm good. Good. And you?
I'm fine, thank you.
We'll just wait a couple of minutes and then we'll start.
No problem.
Okay. Okay, good afternoon, everybody. Welcome to today's meeting of our Department of Pediatric Surgery. The topic is going to be gastrointestinal duplications, and we are glad that Dr. Ellen Mapunda has agreed to be invited guest for today's meeting. Dr. Mapunda did her undergraduate studies at various places, prestigious places, including St. Andrews University in Scotland, University College, London Medical School, and also in Malawi. She did her pediatric surgery training between University of Pretoria and Wits University, and she is now currently head of the pediatric surgery department at Charlotte Makeke, that is previously known as Johannesburg General Hospital. These are her words, which I really liked. She says that I love teaching because I learn from it. My patients have been my #1 teachers, followed by students at all levels. Undergraduates are my favorites. And of all achievements and accolades, one I'm most proud of and grateful for is Mama Themba. So welcome, Ellen, and welcome to all the guests and attendees. We will start as soon as Dr. Helga Nauhaus, our registrar, will be able to share her screen. Helga, you can go.
Hello, everyone. I hope you can see the slides properly.
You can see the slides, but your voice is a bit soft.
Okay, let me try and make it better. Yeah. Let's see if this is better.
It is better, yeah.
Okay, good. I'm Helga Nauhaus. My topic for today is GI tract duplications. Why are they not going forward?
Just try and make your slide full screen, Helga.
Sorry?
Just make your slide a full screen slide.
Let me try again.
Yeah, that's good.
Good. Just some background. It's GI tract duplications are actually quite a rare condition that we don't see very often. They come with a very varied presentation depending on the location and the type. And as we'll go through this presentation, I'll show you where all they come and how all they present. And generally they're comprised of a well-developed smooth muscle coat with epithelial lining and a mucosal lining that represents the adjacent GI tract and is generally attached to the GI tract where it's coming from. Just some embryology. Unfortunately, there's no one theory that explains all GI tract duplications. Therefore, the current assumption is that there's a multifactorial process that is associated with some vertebral, spinal cord, and genitourinary and rectal malformations, and possibly even with intestinal atresia. Currently, we have 5 theories that explain some of the GI tract duplications that we see. The first one is partial twinning. This is where organs or multiple organ systems can be duplicated. It's often seen with hindgut duplications who are associated with genitourinary duplications. So 2 vaginas or 2 vaginal uteruses with a rectal duplication or a rectal cyst. And a split notochord theory says, well, it starts off in the first month, the notochord separates, and the theory says that gaps in the notochord develop that let endoderm herniate through and form diverticula. These are especially seems to be more common in the ones with spinal defects, so higher duplications in the thoraco-abdominal region or ornithorax region. And these duplications can connect to the spinal cord and need to be kept in mind when we try and manage them. The third one is diverticular defects. These are thought to be persistent embryonic diverticuli that form from the GI tract. This was the first theory that was formulated. However, it mostly seems to be rejected now, as diverticuli form from on all sides and surfaces of the bowel, and duplication cysts generally form on the mesenteric side of the bowel. And diverticuli don't often contain the same amount of wall and epithelial tissue as the duplications that we see. The fourth theory is the second one that was postulated. It states that the GI organs start as solid tubes, and in the process of forming lumens, they vacuolate. During this process, diverticuli form, and they usually regress during fetal life, but some might persist until later on, and they then form duplications. And then lastly, because the first 4 don't quite explain all duplications that we see, seems to be any hypoxic vascular incidents or trauma that happened during the embryological or fetal stages. GI duplications are often found incidentally. We do something else and happen to see that they're there. They can be diagnosed antenatally, and in the first world, they commonly get diagnosed antenatally. In our setting, unfortunately, we often only see them once they present with symptoms. They can present with a range of symptoms that start from pain, obstruction, abdominal distension. If there's any obstruction, they may present as intussusceptions, bleeding or perforation if there's ectopic tissue present, or respiratory compromise with recurrent pneumonias, or shifted mediastinoms if it's a thoracic duplication. Their presentation mostly depends on the size and the location and whether or not heterotopic mucosa is present. In our settings, they usually present before 2 years of age. However, sometimes they only present in adulthood with complications of the duplication cysts. They're generally classified into foregut, midgut, and hindgut duplications. They start anywhere from the mouth down to the anus. The most common ones that we see is the jejunal ileal ones, which present about half of them that we see. Next one would be the esophageal ones. And then the third most common is the colonic ones. They can present either spherical or tubular, as you can see on the picture. Here's my arrow here, some spherical ones and then tubular ones. The stomach one is not quite correct because it's often a spherical one and not a tubular one, but it's generally on the greater curvature. We then find some thoracoabdominal ones that are not classified together with the esophageal ones that often track from the esophagus down to the foregut structure, the stomach, duodenum, or sometimes jejunum, and may or may not be connected to the spinal cord. And then some can contain ectopic tissues, that is usually pancreatic or gastric tissue. These can be in esophageal duplications, stomach or duodenal or jejunal and ileal. Usually colon and rectal don't have ectopic tissue. And then to some investigations. Investigations are quite difficult because of their varied presentation. Generally, it's recommended to start with an ultrasound. It's non-invasive and it's relatively easily available. It's also used for antenatal diagnosis if we do find them antenatally. On ultrasound, we can see this double wall sign as these cysts have the muscular layer and therefore thicker walls than normal cystic structures that we see in the abdomen, like mesenteric cysts or mental cysts. And all over the world is the first investigation that we do. However, X-rays often get done first, just purely on the non-specific presentation that these children can come with. And if ultrasound doesn't show anything, X-ray is often our next go-to anyway. They're generally not very helpful, especially for abdominal duplications. However, in the thorax, you might see a structure in the mediastinum or something that's pushing the mediastinum to one side or the other. Or can show pneumonia and complications from these duplications. The next recommended investigation is contrast studies. They may not show spherical duplications, but they can show tubular duplications. For spherical ones, they may show filling defects, and they're especially important in rectal duplications as there might be a fistula to other organs or to the skin from the rectum, and these need to be delineated before we start operating on them. However, these first two studies don't often tell us what exactly is going on, and therefore the next recommended one, especially in the first world, is a CT scan. In our South African setting, go to one if we have it available. In some of the other African countries, CT scan is not readily available, and they will then skip the next few investigations. CT scan can be very useful, as you can see where the structures are located, plan operations, see what other associated structures are close by. On CT scan, we can confuse these duplications with other ring enhancing lesions due to the muscular layer They take up more contrast and therefore look similar to ring enhancement lesions. These need to be differentiated from septic reasons with a septic workup, FBC and a CRP. And if the child is non-septic, there might just be a duplication cyst and not a septic origin. However, in our setting, that can be very difficult as our patients present immunocompromised and often with TB. But then we'll have to investigate and see what it is. MRI is often done in first world countries, not so often in our setting. However, if there's a duplication cyst possibly involving the spine, MRI is very useful to see if there's a connection. And then lastly, the technetium scintigraphy is recommended to check for ectopic mucosa, as that's important for planning operations, especially if we have duodenal duplications. Then coming to treatment, just some principles, and then I'll go through some more detail. And ideally, we would like to excise the duplication completely. However, the surgery should not be more radical than the problem for the child. Therefore, for especially duodenal duplications where operations can be quite complex, we will have to find the easiest solution with the least morbidity for that child. Keep in mind that these duplications are often on the mesenteric site and share blood supply with the native bowel, and that can complicate surgeries. Remember that there might be heterotopic mucosa, and that ideally need to be excised. Depending on where it is, there are some other options available. And then keep in mind the relationship of adjacent structures, which is especially true for duodenal duplications with the biliary and pancreas. And for the rectum, especially if it's anterior duplications, as that will make our surgery very difficult, and we have to think of different options than to just excise the duplication. For more specific management, I'll just run through the different areas briefly. As I said earlier, they can present anywhere from the mouth to the anus. The oropharyngeal ones often present with a mass. They're usually a cystic lesion, not a tubular one. And the recommended treatment is to drain them into the oral cavity, and that usually solves the problem. And the cervical ones can present as cystic masses. There is a very long differential as to what the cystic mass in the neck can be, and usually needs quite a bit more workup than the oropharyngeal ones. And they're usually excised through the neck completely. Esophageal ones are the majority. They generally are located on the right of the chest. True esophageal are usually cystic. However, they share the muscular wall of the esophagus, which can make excision a bit more complex. They need to be removed as they often become symptomatic and can or even form malignant tissue, as they can have ectopic, heterotopic tissue. And they can be approached either through a thoracotomy, or if the skill is available, with thoracoscopy. If the esophageal ones have spinal involvement, generally the neurosurgeons need to be involved, and they start off with the procedure to ligate the connection to the spinal cord, and then we take out the rest of the cyst. This is to prevent infection going and causing meningitis into the spinal cord. Thoracoabdominal ones are luckily relatively rare. They often also sit on the right side, but they can communicate into the abdomen and to the intestinal tract distally. They're usually tubular, and they have a very high percentage of gastric mucosa, which needs to be kept in mind when we do their surgeries. They're usually done with a two-stage approach, where we start off and remove the thoracal thoracic part first and then the abdominal one. However, it needs to be made sure that this drains somewhere, as otherwise it can cause infections. And keep in mind that there's often heterotrophic mucosa, which also needs to be stripped to prevent complications. Gastric duplications are usually symptomatic early. They can present with a similar picture to pyloric stenosis, but they can be at the pylorus, but often on a greater curvature. They're usually cystic, and resection is recommended and is usually relatively easy. Duodenal ones are luckily relatively rare, but are quite complex. They can have varied presentation ranging from gastric outlet obstruction to jaundice to recurrent cholecystitis and pancreatitis. They also have a high percentage of ectopic mucosa that can cause ulcers and perforation, and can be quite difficult to excise given all the structures that are so close to the duodenum. For this, we need the most experienced surgeon to do the operation, and keep in mind that there's multiple options. One more recommended is to try and excise the mucosa and leave the rest to drain into the lumen, as it doesn't come with as much morbidity, but that depends on where the duplication is situated. Small bowel, as I said earlier, is the most common duplication we see. It can either be cystic or tubular. It also commonly contains heterotopic mucosa, and resection is the most recommended treatment. That's usually done with a localized resection of the bowel and in primary anastomosis, as the duplications share the blood supply with the native bowel. They can be mistaken for a Meckel's diverticulum. However, Meckel's diverticulum is situated on the antimesenteric side, and the duplications are situated on the mesenteric side. If we find one small bowel duplication, we must just check the rest of the bowel for any other duplications and excise them also. Keeping in mind, if we have to excise a lot of small bowel to get rid of the duplications, we might excise so much that we have short bowel, in which case we have to come up with a different plan. There are also a few options available for that one. For colonic duplications, again, they can be cystic or tubular. Tubular seems to be the more common one. The smaller ones, again, are resected locally. Long tubular duplications form a challenge. Luckily, they don't usually contain heterotopic tissue, and if they can't be excised, it's just recommended to drain them distally so that they can drain and don't form obstruction. And then keep in mind that there might be fistulous tracts either to the skin or adjacent organs that need to be excised as well. And then rectal ones are also quite a challenge, but luckily not that common. And amongst the rectal ones, the most common one is a presacral, and that's situated on the posterior rectum. Keep in mind that these ones can present with genitourinary and anorectal malformations, and the surgical approach depends on the location. Generally recommended is posterior sagittal if it's localized to the lower rectum. Sometimes a transanal approach can be used, otherwise like in this picture where it's quite a complex and long thing that's connected to multiple things, might need to be laparotomy and perineal approach. The complex ones are the anterior rectal ones, where you also need very skilled surgeon to deal with those because there's so many adjacent structures, and surgery in that space can damage vascular and nerve structures going down to the pelvis. So in conclusion, duplications present in various ways. Luckily, they're relatively rare. They come or can occur from anywhere from the neck down to the anus and can be simple cystic, complex, multiple, or tubular. They can be associated with other anomalies, including the spinal cord anomalies and genitourinary anomalies. Optimal treatment or recommended treatment is resection, and they generally have excellent long-term outcomes and quality of life. Thank you. Are there any questions?
Helga, excellent presentation and a very nice overview of a rare but complex topic. So well done. I'll now invite Dr. Mapunda to make her comments. Ellen, do you have a PowerPoint or you will just talk?
Let me see if I'm able to share.
Yes.
But yes, I enjoyed the presentation.
Yes.
The good summary. It's true, it's very rare.
Yes.
I mean, surprisingly, they quoted at 1 in 4,500, which I think that's not rare enough. We hardly see these things. As Helga was talking, I tried to recall other cases that I have seen. Like I've only seen one in the mouth that we actually thought was a dermoid cyst, but the pathologist told us no, it was actually a duplication cyst from the mouth. But yeah, the jejunal area was seen. And I also recall like one case of a bigger child, adolescent of 12 years, who presented with an acute abdomen with free air, and she actually had a perforated ulcer, but with a duodenal duplication right next to where she had the perforation. I'm just going to try and share.
Yes.
When I saw the topic, I thought I could, what do I do? Share screen.
If you just go right at the bottom, share screen.
Yes, I just want to open the
presentation.
Yeah, the other comment I had is that they don't, which you already said, they don't have any way of presenting. It can be, is my screen showing?
Not yet.
Okay. So like the presentation will depend on the site, and you don't, most of the time you won't even have you won't have the diagnosis until you go to theater. Am I still on?
Yeah, we can hear you talking, but we can't see your screen yet.
Okay, this is bad.
So if that presentation is open, you can just go to share screen.
Yeah, that's what. Well, I've got my presentation on the thing, and then the Zoom is gone.
At the bottom, there is a green arrow. You'll just have to click on the arrow to share screen.
I'm sorry, Miriam. Reduce this, go back to Zoom. And this is the Zoom meeting. Okay, yeah, so I've got my share screen. That's okay. There we go. Is it on?
Yeah, it's perfect now. Yeah.
Okay. No, so just for the purpose of teaching and sharing, I wanted to give you quickly two cases, just recent cases on duplication cysts that we have seen this side. So this was a 4 days old post-death big baby that the pediatrician actually kept that long because she thought the baby is gonna pass stool. But this baby hadn't passed stool and the abdomen was starting to distend. she sent me these x-rays, like as you can see, there is some distension of bowel. This is suggestive of distal intestinal obstruction. On the lateral, you can see maybe, if you see my pointer, you can see some suggestion of stool there, and again, distal intestinal obstruction. So now when the baby arrived from another hospital, that was what we were thinking. Okay, it's a distal intestinal obstruction, and then they said the baby was not feeding well. My thinking was, you know, this baby has got a distended abdomen. It won't be interested in feeding. And then when I did a digital rectal examination, there was just some mucus there. And the pediatrician had tried also to put a feeding tube, she said, and it was stopping. I didn't try that again, but there was an open anorectum, but you couldn't go far with your finger. So at this point, one is thinking the usual things that we know as causes of distal intestinal obstruction, but there's no anorectal malformation, so you rule that out, but you consider the stenosis. This is now, I just asked for contrast. You know, it was obvious the child needed surgery, but I asked for a contrast study. This was the control X-ray. As you can see, you see this quite distended, but you know, you can make out that it might be something that's blind ending there, just below the sacral promontory there. That's funneling down, but quite distended and blind ending. So you think, is this an atresia? What's going on? Then we did a contrast study together with the radiologists, and they were putting contrast from the lateral view. You can see the contrast is kind of bypassing that blind ending tube. You know, at that point, we are wondering what's going on. I'm just showing you the x-rays, you know, inverting the images. And on the AP, you can see the contrast is going beyond what we thought is an atresia. There's still contrast going on in this particular patient, and even a lateral view of it, you know, almost like you've got a sickle, that sickle-shaped contrast going in. So we wondered, and we had long discussions, and the radiologist put this as his differential diagnosis. In theater, this is what I found, or what we found. There was an atresia. You can see this is blind ending. You're looking down into this diva retractor is at the bottom. You're looking at the rectum down there, and this blind ending thing. But when we opened it, it was opened vertically to say, can we open and repair this? Then you say, but something else is going on here. There is this lumen, the proximal colon, let's call it sigmoid. And then you see the rectum, the lumen of the rectum with this mosquito here. That's the one proximal, distal, the rectum, but there's another lumen in between that is not cannulated in this picture. So then one looks at the whole picture. Sorry, I think I skipped. Yeah, so one looks at the rest of the anatomy. You can see that there is a duplication, what you'd call a tubular duplication of the colon. It skips on that bit and then it carries on. Actually, the rest of the colon had that duplication. Like she already said, it is usually on the mesenteric side. So what we did is GIS stapling. I liked it when she said, whatever you do should not be, you know, more than the patient needs. You know, you don't want to take out all the colon. You can't take out that duplication from the mesenteric side easily without compromising blood supply. So in this particular patient, we stapled with this 45 centimeter twice, just to make these two lumens communicate well. And then proximally also just made an area on the proximal transverse colon to make it communicate. And that's all that was done. And then, of course, the primary anastomosis in view of the atresia. So this was double pathology, atresia with duplication of the colon. And then the last case, just quickly, this child, when she presented, she's almost 2 years old, she presented as a prolapse. On our meetings, everyone was like, there's a child with a prolapse. This thing was, mom noticed recently, this thing coming in and out, coming out and back in, and eventually on ultrasound and CT scan, they diagnosed a duplication. I think this doesn't project well, but it was duplication of the sigmoid as well as rectum. So what we did is to just, we examined, and maybe we will need to do something further. This is very recent, 3 weeks ago. We found that there was a fistula into the duplication. So it would fill up with feces, mucus, then it would protrude out, then it would decompress itself. So basically we used that fistula to make the duplication of the rectum communicate with the main rectum, and we stimulated and checked, it was within the sphincter complex. So that's what I wanted to share as to what we've experienced on this side in terms of duplication. Both of these cases are the colon duplication. Thank you.
Thank you, Ellen. Very excellent cases, and a very nice practical demonstration of diagnosis and of management. So I'll now, any other comments, Ellen, about the topic in general?
No, I don't have any other comments.
Okay, thank you. I see we have Prof. Hadley present with us. Prof. Hadley, any comments from your side? Any different?
Yeah. Hi, and good afternoon, everybody. Yeah, I'd just like to congratulate Ellen for spending part of her undergraduate training at such an excellent university.
I thought you will it from that.
At the University of St Andrews. Yeah, yes. I imagine I was there a few years before Ellen, but yeah, St Andrews never changes. Yeah. I think the cases Ellen's presented exemplify all the problems. And I'm embarrassed to say, actually put a gastrostomy into a gastric duplication and wondered why it didn't work. But the commonest ones that we've seen have been in the tongue. And the cystic duplication in the tongue, it's related to the foramen cecum, but they are, to all intents and purposes, cystic duplications. And those we've assaulted by splitting the tongue in two down the midline, and you can easily access the cyst, remove it in its entirety, and close the tongue back up again with little morbidity. The only other ones that we've encountered have been duodenal, and you can't excise these. You've got to make some other plan. And whether you drain it into the main duodenum, or you drain it into some roux loop, or you excise the mucosa and drain the remnant, you've got to make some other plan other than trying to excise them, because I'm sure you'd end up in misery. I'm always concerned when the registrar says that this needs a brilliant surgeon to be able to do these operations. I mean, surgery should be easy. If it's difficult, it's probably not the right solution to the problem. Thanks.
Thank you, Prof. I just invite now Dr. Machaya, who is our consultant pediatric surgeon, to make comments or share any experience, knowledge.
Yes, thanks, Prof. And thanks, Helga, for that presentation. I think the important thing is just, if you have suspicion of it, you've actually won the case, because it's not common that you'd sit in any kind of differential and off the top of your head think it's a duplication. That's why we generally just find it intra-op. Because my experience, I remember it was like a lady in her 30s who came in presenting with a free A, which everyone thought was a duodenal perforation. But intra-op, when we actually, we actually found that she had a tubular transverse colon duplication, which we actually managed to excise and actually had an untoward recovery. But I think suspicion is very important, and then you can plan your management thereafter. But the thing that Dr. Mapunga was actually alluding to, which I actually wanted to ask Helga about the using a linear stapler, especially with the transverse colon, because we find it difficult to actually separate the duplication from the actual colon itself, because it's intermittently running or sharing the same blood supply. So the least damaging thing to the patient would definitely be to join the lumen, as was done in the case that was shown now. And ultimately, I think that would help. And it's actually okay. It's actually okay. Sorry, no more comments.
I see we have got the entire family attending the meeting. Okay, Selo, thank you. I'll invite Dr. Majola, our other consultant pediatric surgeon, to make any comments. Dr. Majola.
Hi, Prof. Thank you for the opportunity. Nice presentation, Helga, and also just the cases that Dr. Mapunda showed us. Yeah, my comment was basically, as said, you want to do minimally as you can and what is actually required for the patient. And they also do mention that obviously depending on the size of the duplication, the non-communicating, you create them to be communicating, and that's all that you might need to do for those patients, especially as I said, there's closely related to the structure of origin, and also they share a common blood supply. So you don't want to mess with the blood supply and cause further damage to the patient. Thank you.
Okay, thank you, Kunleko. I see Prof. Delgado from UMTATA is also here. Arturo, any comments from your side? Any experience? I'm sure.
Well, good afternoon to everyone, especially to my friend Larry. So I have to be honest, and I'm embarrassed to say I have only have the opportunity in my 37 years of pediatric surgeon to treat one patient with gastric duplication. That patient was on several years ago in Mozambique, was a 61. Was the diagnosis was wrong because we took it like mesenteric 6 because it was huge. And then we did a resection and no complication after that. So that's the only comment I can do and say my experience on this, that is very poor. Thank you.
No, that's perfect. I think you are very honest, Arturo. There is nothing wrong in that. These things are quite rare. And thank you for being honest. I see Dr. Coppola is also here, a consultant pediatric surgeon from UMTATA. Funeko, any comment about the topic?
All right, thank you, Prof. I'd like just to say hi to my friends from Joburg, Ellen, and congratulations for such an excellent job that they're doing that side. And I want to congratulate the presenter. But other than just choose the topic, I don't have any comments. Thank you very much, Prof.
Thank you, Funeko. I see there are colleagues from rest of Africa also joining. Anybody who wishes to make any comment, please just unmute yourself and make a comment. Anybody wants to make a comment, ask a question? Do you face any difficulties?
Meaning just only to bring something about history.
Yes.
So there's one from the rectum, that's duplication there. There was recognized many, many years ago at Middeldorf tumor. So just a short comment about it.
Okay, okay, thank you. If there are no more comments, it is nice we are ending this meeting much ahead of time, but I thank Helga for a nice, simple presentation, clear cut, and for Dr. Mapunda for participating in the meeting and sharing her 2 excellent cases with us. And as usual, Prof. Hadley and Prof. Delgado and all the colleagues, Dr. Funeko Kopolo and all the colleagues from rest of Africa. You are most welcome to join. We appreciate your presence. Next week, there will be presentation on inflammatory bowel disease in children. And we are very glad that Professor Robin Brown from Cape Town will be our invited guest. So you will soon get invitation of the meeting next week. And I'll also put the link to the recording of today's meeting in case somebody joined late and would like to watch the recording again. Thank you all. Have a good evening.
Thank you so much. Thank you so much, Prof.
Thank you, Ellen.
Thank you.
Great to have you. Bye-bye.
Thank you, Prof.
Bye.
Bye.
Good evening, everyone.